Hello everyone. So it's me again, Bernina from Aptisen. So I'm a medical affairs lead at Aptisen, and today we are really happy to present this live webinar on the clinical updates on Synolis VA, and we'll have as a speaker today Professor Bruyère, who is a professor of the clinical epidemiology in the University of Liège in Belgium. And we have also Professor Corté, who is a rheumatologist from and the head of the rheumatologist department from the University of Lille. So today we have a two-part presentation. So the first part will be presented by Professor Bruyère, and he will give us an overview of the management of knee OA and the place of viscosuplementation. Then we will switch on the clinical studies that we just obtained on the RCT presented by Professor Corté. And we will have a Q&A session at the end of both presentations, where you will be able to ask all the questions that you want on the right side of your screen. You can see the section question, and you can write all the questions that you want, and we will ask those questions to the speakers at the end for the Q&A section. So now I leave Professor Bruyère start his presentation.
Thank you very much, Bernina, for this kind introduction. And indeed, this is my privilege
Professor
today.
Bruyère, I think that your microphone is on mute.
Is that better now? Can you hear me?
Yes, perfect.
It's perfect? Okay.
Yeah.
Okay. So once again, thank you very much for this kind introduction. And this is indeed my privilege to discuss with you today the management of knee osteoarthritis according to recent guidelines and the place of viscosupplementation. So what I would like to do today is to briefly discuss the various guidelines in order to have some kind of thread where we can see the place of viscosuplementation. You are obviously aware that osteoarthritis is a major public health problem with a lot of pain, a lot of stiffness, physical function, and so on, according to different systematic reviews, observational studies. We know now that hip and knee osteoarthritis is a major burden of the global disability that quite surprisingly increases with time, at least over these last 2 or 3 decades. I would say that the excellent news for osteoarthritis is that we have some effective treatment, and we have also different guidelines, so some quite old guidelines, but some very new guidelines for the management of osteoarthritis. And basically, these guidelines are very interesting, and they try to assess the effectiveness of different interventions. And it's especially the case for the American College of Rheumatology guidelines or the guidelines of the Osteoarthritis Research Society. What I would like to discuss with you is obviously these guidelines because they are very interesting, but also discuss the algorithm that we have proposed, or at least an updated algorithm. Just for your information, we proposed a couple of years ago in 2014 the first algorithm for the management of knee osteoarthritis, and we have updated this algorithm last year. I think it's quite an interesting algorithm because for the very first time, we try to have a step-by-step approach of osteoarthritis, of the management of osteoarthritis. And let's be clear, I would say that a substantial proportion of these algorithms is perfectly in line with what could be observed in other guidelines. Of course, there are some differences, and we can discuss after why we have some differences across guidelines, but basically we have here a step-by-step approach, including some basic principle and some core set of therapies, and then we have 4 different steps. What I propose today is briefly to discuss all these different points. The first is the basic principle is that we need to have a combination of non-pharmacological and pharmacological therapy. It's strongly recommended, and by the way, it's recommended by all national and international societies. And then we have a core set of therapies, including information, education of the patient, including also weight loss if the patient is overweight, and including also exercises therapy. Let's be clear, we know that information, education, weight loss, exercises are very important. It's a high level of evidence-based medicine, so we know that it's very effective to reduce the pain of the patient, to improve the physical function of the patient, and some clinical trials have also suggested that it's even cost effective. So it's worth it from a budget point of view to prescribe education, information, weight loss, and exercise program. Just a very brief comment regarding the exercises program, because last year a very interesting manuscript, quite provocative, was published, and basically they say that we do not need any more randomized controlled trials on exercises in osteoarthritis. And why? It's because we perfectly know that it's effective. Whatever the kind of exercise, aerobic exercises, strengthening exercises, resistance training, it's effective. So I think that the good point for you that are prescriber is that you can prescribe what you want or what the patient wants. And I think it's very interesting because we can increase and improve the compliance to the patient if the exercises proposed to the patient is really something that the patient likes. Of course, I know clinical trials have suggested, and you know as clinicians, that information weight loss exercises are probably not enough in order to manage the patient. So we have the first step, it's the background treatment, with first a referral to the physical therapist in order to control for malalignment with knee braces or insoles, because in some patients it has been shown to be useful. And of course, we can ask the physical therapist to try to reduce the pain of the patient and to improve the physical function of the patient with some education to use walking aids, but with also the prescription and the use of thermal agents, manual therapy, taping, aquatic exercises, Tai Chi, or even electrical therapy. Of course, we know once again that it's probably not enough to fully control the symptoms of the patient. And at the level of SKO, we propose a background treatment with the chronic use of symptomatic slow-acting drugs such as glucosamine sulfate or chondroitin sulfate, with the use, if needed, of paracetamol. Why? But it's clearly because we have some high-quality trials suggesting that glucosamine sulfate, chondroitin sulfate, maybe also diacerin and avocado soybean and saprophynifiables could play a role in the management of osteoarthritis by reducing the pain of the patient and improving the clinical function, the physical function of the patient, with also some data suggesting that we could also have an effect on the structure of the joint. So probably as a background treatment, it makes sense. And it makes sense also because of the excellent safety profile of this treatment. you know that this treatment will be given for years, and the background treatment will be given for years. It was previously the case with paracetamol, but now we think that we really need to have an effective treatment, but with an excellent safety profile. And clearly, when we look at recent systematic reviews and meta-analysis, symptomatic slow-acting drugs such as glucosamine sulfate and chondroitin sulfate could be considered as safe. Just an important point, and basically it's the same for the rest of the presentation, but we said quite clearly here that we would like to propose a prescription grade, pharmaceutical grade glucosamine sulfate and chondroitin sulfate. Why? It's clear. It's because we have some independent meta-analysis published 5 years ago suggesting that only some specific formulation could play some role in the management of osteoarthritis, while in other brands with other formulation of this product, we have no effect at all. So highlighting once again the importance of the product. And that's why, once again, at the level of SQ, we published a position paper a couple of years ago saying that we only recommend to use formulation clearly supported by evidence-based, so where we have clinical data. So I think that if you have to prescribe something, you need to have a look at the clinical data in order to be sure to be and to prescribe some evidence-based medicine. Of course, still in the background treatment, and if the patient is still symptomatic with the chronic use of symptomatic slow-acting drugs, we recommend at the level of SKO to use topical NSAIDs, mainly because first of the excellent safety profile, but also because it has been shown to be quite effective, at least over the first week of treatment. We know that after 3, 4, 5, 6, 7, 8 weeks of treatment with topical NSAID, it's less effective, but at least in the initiation of the treatment, it's quite effective. So in the background treatment, we have some treatment with some effectiveness, with some effect on the pain, some effect on the symptoms, but also with an excellent safety profile. And then we move to the second step with a more advanced pharmacological management of osteoarthritis with the use of oral NSAIDs. We recommend the use of intermittent or longer cycle oral NSAID, mainly because of the effectiveness of oral NSAID to improve the pain of the patient, to improve the function of the patient. The effect is larger than paracetamol prescribed 20 years ago, but in the same range of what could be observed with symptomatic slow-acting drugs. We do not have very important differences between different NSAIDs to improve the pain of the patient. And of course, because of some safety concerns, we try to not prescribe NSAIDs, and we do not recommend the use of NSAID as a chronic use, but more as a longer cycles use. Of course, NSAID selection is dictated by risk of the patient, basically the gastrointestinal risk, cardiovascular risk, and renal risk. I think it's very, and so let's be clear at the level of SKO, and I think it's the case in most of the international recommendations. We do not recommend one specific oral NSAIDs, even if we have some data now suggesting, for example, that celecoxib could be of potential interest to reduce stroke and cardiovascular events. But once again, the use of oral NSAID must be dictated by the risk factors of the patient. At last, systematic review and meta-analysis published a couple of weeks ago by the team of Tim McAlinden was very interesting and shows the duration of the symptoms relief after the use of oral NSAID. And you can see quite clearly that it's quite effective. During the first 2 weeks after the initiation of the oral NSAID, then we have a reduced efficacy, I would say, from week 4 to week 12. And then we have a reduction of the effect after half a year with some kind of heterogeneity among patients. Once again, we could have patients that could still have some important effect of this treatment, but some with less effect over the long term. Of course, if the patient is still symptomatic, or if the patient is contraindicated to the use of oral NSAID, we recommend at the level of SKO the use of intra-articular injection of hyaluronic acid or corticosteroids. If we focus to hyaluronic acid, we know that it's beneficial in most of the meta-analysis, even if we should acknowledge that we have some huge heterogeneity among the meta-analysis, but also among the clinical trials. We have an effect size, once again, within the range of what could be observed with oral NSAID, with symptomatic slow-acting drugs, but with a longer lasting efficacy for more than 6 months after the treatment. It's generally well tolerated. I think that it will be discussed later on. Probably that the magnitude of the clinical effect could be different according to different products, but once again, it requires further investigation. But once again, I think it's important to prescribe a treatment when we have clinical data. So of course, hyaluronic acid is recommended by the SKO task force. But if we look at the recent guidelines of the Osteoarthritis Research Society, it's interesting to have a look at the place, once again, of viscosuplementation. And the ORC has performed an excellent review of the literature with a recommendation by experts. And basically, they have level 1, 2, 3, 4, 5, according to the percentage of experts in favor or against a specific treatment in a specific condition. And if we look at the main table for the recommended treatment for knee osteoarthritis, we can see that we have a level 2 for intra-articular hyaluronic acid injection in patients without comorbidities. And if I come back to my previous slide, you can see that level 2 is that we have more than 60% of the experts saying that they are in favor of this treatment. However, and interestingly, if we look at patients with gastrointestinal disorder, cardiovascular disorder, or frailty, hyaluronic acid injection is still recommended, but at the level 1. So it's highly recommended by subject. And in patients with widespread pain or depression, it's still in the level 2. So whatever the kind of patient, at the Osteoarthritis Research Society, they also propose the use of viscosuplementation in patients with knee osteoarthritis. Regarding corticosteroids, we have some evidence that it could be interesting in patients with joint effusion. We have higher efficacy than viscosupplementation just after the administration, but of course, you know that it's a real short-lasting effect, even if the safety is quite acceptable. Of course, you know from your clinical practice that even with the use of the core set of therapies, the background treatment, the oral NSAIDs, the viscosupplementation, some patients could still be symptomatic. And so we should try the last pharmacological treatment and we recommend mainly at SKO the use of short-term weak opioids or maybe the use of duloxetine, because we know that it's we have some clinical trials suggesting that duloxetine could play some interesting role in the management of osteoarthritis, but also because it's quite widely used in different countries. And of course, regarding the short-term weak opioids, we know that it's highly effective, but we know that we have some safety concern with the use of these weak opioids. But we also know that we have some data suggesting that some kind of sustained release formulation could improve the tolerability of the patient, but it has to be assessed over the long term. And of course, if the patient is still symptomatic, then we have the end-stage disease management, mainly with the use of joint replacement and total joint replacement. And we know that it's a highly effective treatment with a major improvement in the function of the patient, major improvement in the pain of patient. We also know that it's highly cost-effective, so it's something that could be recommended. But of course, if contraindicated to surgery, but then we have to go to classical oral opioids, analgesics. So I think that we have to help clinicians some recent guidelines performed with high level of sciences, with real experts in their fields, with methodologists, using a systematic reviews approach. And I think that the major advantage of the most recent guidelines, including the guidelines of the Osteoarthritis Research Society and the guidelines of SKO, is that we have a more step-by-step approach, really to help the clinician. You know that 10 years ago, we only knew if this treatment was effective or not effective. But now we know when we have to use it, and I think that it's probably more interesting for the patient. So probably now that we have most of the treatment proposed in a quite logical sequences, even if once again we have some differences between different guidelines. Once again, I think that we can discuss it later on if you want to discuss it. And regarding the place of viscosupplementation, I think that clearly there is a place for viscosupplementation, probably in patients with severe symptoms or contraindicated to oral NSAIDs, or maybe in other specific approach with specific patients. The major advantage is the longer lasting efficacy. And once again, keep in mind that it has been recommended by the most recent international guidelines. So thank you very much for your attention. I think that Professor Corte will now discuss more specifically some recent data related to the use of viscosupplementation, and then I will have the privilege to try to answer your questions. Thank you very much once again for your attention.
So now, Professor Corte, you can start your presentation.
Yeah, but may I have the first slide, because I don't see the first slide, so it will be difficult with those slides to do my presentation. Perhaps it will be possible, but I'm not sure that it will be easy for me. Yeah, okay, right, I have that. So good evening, ladies and gentlemen, and once again, I would like to thank Professor Bruyère for this overall presentation regarding the management of knee osteoarthritis. My name, as indicated by Bernina, my name is Bernard Corte, and I'm a rheumatologist, professor of rheumatology in France, in Lille, which is in north France, very near Belgium. And it's for me really a great honor, privilege to present this study, which it's a comparative studies between two hyaluronic acid. The first one is a Synolis, and the second one that you know, I think, is a Synolis. But previously, I would like to focus on some points. Obviously, I don't want to repeat that Olivier said, but I would like to focus on the positioning of hyaluronic acid in the management of knee osteoarthritis. The first point, as indicated on this slide, is obviously that hyaluronic acid is not for all the patients, but for patients with a failure of analgesic. And in my opinion, the level of evidence is not exactly the same as compared with NSAIDs, because the positioning is after a failure or problem of safety with NSAIDs. So in this case, we have several possibilities, as indicated by Professor Bruyère, and we can imagine that you can have some positioning for use intra-articular injection. May I have the first slide, the next slide? I'm sorry. Yeah, thank you, Ronia. So as indicated by Professor Bruyère, there are theoretically three possibilities that are indicated on this slide: to use a corticosteroid injection, to use a viscosuplementation. I will give you some information regarding viscosuplementation. And the third possibility is to use PRP. We participated recently with Professor Bruyère to a working group, and we published this data for additional treatment of knee osteoarthritis. And at present, it is, in my opinion, it is difficult to positioning PRP, because we have some data, but we are lacking of really solid data. So the difference between the corticosteroid use of viscosupplementation, I think, is relatively simple, because using corticosteroid injection need to have an effusion in the knee, and so the positioning is not exactly the same as compared to viscosupplementation, and obviously the mechanism of action is not the same. So clearly, the positioning of viscosupplementation is represented by patient with a high level of pain, with a failure of analgesic, but for knees without joint effusion. May I have the next slide, please? One question is related to the mechanism of action of hyaluronic acid, and clearly we have several hypotheses, but we don't know exactly the mechanism of action, but we can imagine that, and we have some data related to this finding, we can conclude that hyaluronic acid restores the properties of synovial fluid with an improvement of mechanical, but also obviously, and is the main finding, with an analgesic effect and perhaps an anti-inflammatory effect. Data regarding the effect on cartilage are not so numerous, and I don't think that we can consider that there is a clear protective effect on cartilage using hyaluronic acid. But obviously, it is a relevant therapeutic option. Next slide, please. One concern is that we have the possibility to use several hyaluronic acid with several differences, and on this slide are indicated the difference, main difference, according to the product used. So there are some difference in terms of molecular weight, but also in terms of viscosity, in terms of concentration, in terms of origin, avian or bacterial fermentation, and also, and there is a debate on this point regarding perhaps the efficacy to the characteristic of a product in terms of crosslinks or not crosslinks. And according to the data published on the literature, perhaps the two main findings are the molecular weight and the concentration. And my opinion is that the more important finding is the concentration. May I have the next slide, please? So on this slide is summarized the main difference, the main characteristics of the different possibility for hyaluronic acid. And other possibility is to use, obviously, iron, which is not, it is hyaluronic acid, but is a derivative of hyaluronic acid. If you look at meta-analysis for indicating the difference between the different hyaluronic acid, in the first meta-analysis indicated on this slide, you can see that finally the influence of molecular weight is not so important. And in the second meta-analysis, the most important finding seems to be the concentration of hyaluronic acid, which can improve the viscosity. I have the next slide, please. So it's my pleasure now to really present this study. It was a study, as indicated, comparing two hyaluronic acid. The first one, as considered, I'm not sure that is true, but it is considered that the gold standard, and as you know, it is a cross-link hyaluronic acid. So the first one was the simplest one that you know, to compare the efficacy with another product, which is a non-cross-link product, which is named Synolis, which is a sodium hyaluronate mixed with sorbitol. And we did this study for a duration of 6 months, and the main criteria for evaluating the efficacy and the comparison of efficacy of these two drugs was at 6 months evaluation. I have the next slide, please. In terms of inclusion criteria, the inclusion criteria was represented by patients with obviously a knee osteoarthritis, but with a relatively high level of pain, defined on the WOMAC pain score, defined by a pain higher than 40 millimeters. Yeah, thank you. As indicated, it was a prospective, randomized, double-blind, controlled, multi-center study, and it is clear that it is difficult to imagine that at present a product could have a higher efficacy as compared with a gold standard. So it was a non-inferiority clinical trial, and also it was not a placebo-controlled study because at present, as indicated by Professor Bruyère, we have a high level of evidence indicating the efficacy of hyaluronic acid. So for the other may I have the thank you. For the other inclusion criteria, they are indicated on this line. It was patient between 40 in terms of age of between 45 and 80 years, and obviously we use in terms of criteria of selection the Kellgren and Lawrence grade, and so as is very usual, we included only patients with a grade 2 or 3 using this scale. It is obvious that, as I previously indicated, there is no clear place of viscosuplementation for a patient with a very low level of destruction, and in the other component, it is clear that a patient with a very severe disease, and for example with a grade 4 according to the Kellgren-Lawrence classification, it is a patient who need a replacement of the joint. So it is very classical on this type of studies to use patient with a grade 2 or 3 using the Kellgren and Lawrence grade. May I have the next slide, please? So, as indicated, the main objective of the present study was to demonstrate the non-inferiority of Synolis as compared with Synvisc 1 after 20 weeks of evaluation for patients with knee osteoarthritis with grade 3 or 2 using the Kellgren and Lawrence classification, and after failure of analgesics and also NSAIDs, or also for patients who not tolerate these kind of drugs, or also because the doctor said that there is an indication to use a visco induction. In terms of primary endpoint, we analyze the change from baseline using the WOMAC pain score, and we define the lower margin of non-inferiority obviously in a pre-specified manner, that the difference between the non-inferiority was at 8 millimeters using a per protocol analysis, as is usual in this type of study. Also, we have several secondary objectives, and one of the secondary objectives was to compare the evolution of pain severity not only at the end of the study but also at D7, also using the WOMAC pain score, and also we compared the evolution of main symptoms, high hip pain, but also function, but also stiffness associated to knee osteoarthritis at D7, D28, D84, and obviously at the end of the study. And obviously, we analyze the safety of the two products over time. May I have the next slide, please? On this slide is shown the main the flow chart, the main characteristic of the population. So we had logically 3 populations. The first one was a safety population. The second population was the ITT population, and finally the third one population for analyzing the main criteria of evaluation was a per protocol population. So we include 201 patients, and on this slide is shown the main characteristic of the population, which is very classical. A majority of women, about 2/3 of women, with a mean age of 65 years, with a relatively high BMI. The main percentage of the population was in the overweight range, and some of the patients were obese patients. About 2/3 of the population had grade 3 on the Kellgren and Lawrence classification, and 1/3 of the grade 2. The beginning of the osteoarthritis was about 5 years, and at the evaluation at the beginning of the study, the level of pain was high, with on the VAS a level of pain of about 60 millimeters. Next slide, please. So I would like to comment this slide because the main result of the study. I'm sorry. Oops, I have my slide kit have disappeared. Yeah. Okay. Right. Good news. Just I would like to methods for the full screen. So I would like, as indicated, to comment this slide because it's the main finding of this study. According to the main inclusion criteria and the main objective of the study, I have two messages. The first one, that the two products are with very important decrease of pain and a very quick decrease of pain. And also, and this is the main finding, obviously, that in terms of the main criteria of non-inferiority, as you can see, there was no difference between the two products because we define the level of non-inferiority for 8 millimeters, and the difference between the two groups was of 7.2 millimeters. So in terms of decreasing of pain using the WOMAC pain score, you can see that there was no difference between the two groups, but there was obviously a strong effect of the two products. And for example, for Synolis, we observed a decreasing of pain of about 30 millimeters for VAS on the WOMAC pain score, and the decreasing of pain was similar of 31 millimeters in the slide as indicated. So clearly no difference between of the two products in terms of efficacy regarding the evolution of the WOMAC pain score. May I have the next slide, please? Obviously, as I previously indicated, we evaluated also other parameters over time. And as you know, using the WOMAC, there is other possibilities as compared to only pain changes. So I would like not to comment the pain changes because I did some comments on this finding, but I would like now to focus on the other parameters that we can measure using the WOMAC, and particularly the stiffness. As you can see on this slide, there was an improvement of stiffness in the two groups, but without difference between the two groups, as you can see if you look at the p-values. And if you look at another component of the WOMAC, i.e. the function, you can see that there was an improvement of function in the two groups without difference with p, which was not significant. And obviously, if you look at the change for the WOMAC total score, there was an improvement without difference between the two groups over time. Next slide, please. This slide is not exactly the same because on this slide you can see the evolution of the different parameters over time and the comparison between the two groups. As you can see, for example, for pain, as I previously indicated, there is a strong and very quick effect regarding the improvement of pain without difference as indicated between the two groups, and also with results that are maintaining over time during all the duration of the study. So it was the case for the evolution of pain on the WOMAC scale, but also for the stiffness, for the function, and also obviously for the WOMAC total score. May I have the next slide, please? Another approach, another possibility is to consider the percentage of patients who respond to the treatment. And as you know, there is a possibility to analyze these parameters by using the Homeract ORC criteria. So for a therapeutic option using this criteria, a responder is defined as an improvement in pain or physical function with a decrease of the parameter higher than 50% is one point, and the other point is also to have an absolute change greater than 20 millimeters. It is the first possibility. And the second possibility to consider that a subject is a responder to a therapeutic option is an improvement higher than 20 millimeters, and also with an absolute change greater than 10 millimeters. And if you use this criteria, you need to have this criteria for at least two of the following parameters: pain, physical function, and also patient's global assessment. And if you use these criteria of response of treatment, you can see that firstly, there was no difference between the two groups, and also that we have a great proportion of patients with a response to the treatment, because in the Synolis group, this percentage that was about 77%, and this percentage for the Synolis group was about 79%. And obviously, as indicated, there was no difference between the two groups. Now we will move on safety. We did not have a safety concern in this study, and I previously indicated the characteristic of the population for the safety evaluation. As you can see on this slide, the rate of adverse events which need to study discontinuation was very low and was no different. Between the two groups, and this percentage was about 3.5%. Also, if you know, you consider the severe adverse events. So the severe adverse event were defined as is usual by adverse events that need an hospitalization. You can see that this adverse event was very low, without difference between the two groups, 4 in the Synolis group and 3 in the Synolis group. Obviously, we did not observe deaths during the study, and also it is an important point, we did not observe the allergic reaction during the study. Also, we did not observe infection in the course of injection. I have the next slide. So in conclusion, if you look at the design of the study, the main objective of the study was to compare the efficacy of the two products, Viscosuplementación and Synolis, for painful and symptomatic knee osteoarthritis by using the WOMAC pain score and the difference between the 6 months and baseline using a per protocol analysis, and we did not observe any difference. So we consider that there was a non-inferiority of Viscosuplementación as compared Synolis, as compared with Viscosuplementación. And also we used another criteria based not on the per protocol analysis, but based on the modified intention to treat analysis, And using this population, we also observe a difference between the two groups that was lower than the pre-specified criteria, because the difference was about 7.9 millimeters, so it was lower than the 8 millimeters that we considered, and as I previously indicated. And finally, in terms of safety, the safety was correct, and we did not observe any difference between the two groups. So thank you very much for your attention, and perhaps, and we hope, Professor Bruyère and myself, that we will have a lot of questions regarding the two talks.
Thank you very much for both and the high quality presentation that we had. And now we will open the Q&A session. So if you have any questions, you can write them down on the question section. And but someone raised his hand, so I think that he can ask the question directly. So it's Hugo.
Bernina, may we see the question?
Yes. So
and
the person.
Where is it?
So it will. The person will ask the question. Hugo Rodilla. Yeah, just 1 second. But in the meantime, we have also another question. How do you explain the change so the question is for Professor Bruyère. How do you explain the change in the guidelines over the last 10 years, or over the past 10 years?
That's of course an excellent question, but let's be clear. If we look at the previous guidelines, I mean, it was the guidelines of the European League Against Rheumatism from 2003. We had some guidelines of the American College of Rheumatology, and so probably that we have more and more sciences. So it's clear. So we have more clinical data. The second point is that we focus slightly more on the safety. I think that now we strongly believe that safety should really come first, and especially when we use treatment over the long term. That's probably why, for example, the chronic use of paracetamol has been downgraded. You know that in the guidelines published 20 or even 10 years ago, paracetamol was still proposed as the first-line treatment. And now, if you look at guidelines from the American College of Rheumatology, European League Against Rheumatism, Osteoarthritis Research Society, the SKO, paracetamol is not recommended anymore. So I think that we have more data regarding the clinical efficacy and a focus on the safety. That I think that it's two of the reasons why we have some change in the guidelines now compared to old guidelines.
Okay, thank you. Professor Corte, I have a question for you. Do you think that it's mandatory to repeat the intra-articular injection of hyaluronic acid after 6 months?
Yes, it is a possibility. I think obviously there is a possibility, and it is very usual to perform another supplementation. For example, in France, the duration is about 1 year, but if you have responded to the treatment, and if after, for example, 6 months, there is no clear there was in first time a response to the treatment, but in other time progressively an increase of pain, I think obviously there is a possibility to repeat. The delay, the duration is not so clear. It should be 6 months, perhaps 9 months of 1 year, but obviously you have the possibility to repeat the injection.
Okay, and so it's another question related to so can we expect a longer lasting effect beyond 6 months? I know you just say about the French experience, like up to 1 year. So
yeah, obviously, as indicated, the duration of the study was 6 months. So I have no data for example, 9 months and 1 year. But obviously, it is possible to have an effect that for a longer period than 6 months.
May I add something regarding this?
Yes,
obviously.
Because and to confirm what you say is that we do not see a trend in a reduction of the effects over the 6 months here in this clinical trial. So we have a flat line. So an important decrease in pain, and then the stabilization of over 6 months. So I think it highlights the potential effect of this treatment over the short term.
Yeah, I fully agree, and clearly, as indicated, the results are maintaining over time without any difference between the two products.
Okay, and in your practice, Professor Corte, how will you base the use of viscosupplementation? Is it regarding the dosage, the volume, 2 ml, 4 ml? So do you base the selection of the product on the dosage or the volume?
Yeah, I think the two parameters are these two parameters. And a few years ago, as you know, we use products for several weeks. 1 week, the first one, it is the first week, and the second one was the second week, and the third one was at the third week. And at present, I think it's easier in terms of management, not in terms of efficacy, but perhaps in terms of safety, to use products with only 1 injection as Synolis, or as, for example, Synolis, but in France, for example, was another product with just 1 injection, such, for example, Go on 1 or Synolis Synovial 1.
Okay, thank you very much. Based on this clinical trial results, do you think that there is an advantage to use a cross-link product versus a non-cross-link product?
Clearly, no. As indicated in my introduction, there are several differences between the different types of hyaluronic acid, but the question is whether these differences are characterizing by difference in terms of efficacy or safety. And there is an argument indicated that cross-link is very important as compared with not cross-link, but clearly the result of the study that present indicated that this characteristic is not so important. Perhaps it's not the case for all the hyaluronic acids which are not cross-link. It is the case for the Synolis.
For Synolis, yes. Okay.
And may I once again, but once again, it highlights the importance to perform a clinical trial for each product, because we see non-inferiority, but we have data in the literature suggesting that we could have some differences in between products. So once again, I think that it's very important to use a treatment when we have clinical data.
Yeah, I fully agree. We have several products, but the level of proof, the level of evidence according to clinical study is not the same according to the product.
Yes.
Yeah, thank you. So I think that we are reaching like 7 p.m. The session is now finished. Thank you very much again, both of you. It was really an honor for us to have you both presenting the first part on the management and understanding all the guidelines and how it evolved over the time, and also the second part with Professor Corté. And so all the Aptisen team, thank you, and let's keep working together.
Thank you very much.
Yeah, thank you very much for organizing this meeting, and thank you also to Professor Bruyère, and have a nice evening.
You all, bye. Thank you very much.
Bye bye.
Bye.
Bye.